Today, I'd like to briefly go over the role of 3D and TEE in complementing transthoracic echocardiography in adults with congenital heart disease. Now, I would like to step back and take a look at the past, because this morning I was really touched by Dr. Kaleha's talk on the history of echocardiography. We too share a history of adult congenital heart disease and how it became the youngest specialty of cardiology. Over 100 years ago, William Osler wrote the book, The Principles and Practice of Medicine. This was a 1,079-page book with a very small section on diseases of congenital defects. And he thought at that time they were hopeless and futile and not much could be done about them. However, he had two students who begged to differ. One of them was Maud Abbott. She went on to McGill University to write the first atlas of congenital cardiac disease. In this atlas, she classified the different defects, and her description is still held very highly in the world of congenital heart defects. Another one needs no introduction. That was Dr. Helen Taussig. She's the person who explained the physiology and the idea about doing the first blue baby operation to Dr. Alfred Blaylock at the Johns Hopkins University. Little is spoken about Mr. Vivian Thomas, who was actually Dr. Blaylock's right hand. It's a very interesting story that actually became into a movie and later on into a TV movie as well. Mr. Thomas was in Tennessee working to get a degree in medicine when his family lost all their money with the Great Depression. Due to his social and economic problems, he went on to work as a lab assistant with Dr. Blaylock. And later on, when the final Blaylock-Taussig shunt was performed in the operating room, Dr. Blaylock had him by his side. In 1953, Dr. John Gibbons described the first heart-lung machine. They performed the first successful intracardiac operation for the closure of an atrial septal defect in an 18-year-old female. Unfortunately, there wasn't much success following the surgery, and he gave up the idea altogether. A few years later, Dr. Kirkland at the Mayo Clinic made some modification and published a report of 8 cases of intracardiac surgery with the aid of a mechanical pump oxygenator system. This led to the revolution in the world of intracardiac surgery for congenital heart defects. This morning, you may have briefly heard about Dr. Paul Wood. Born in India and raised in Australia, this brilliant cardiologist went on to write one of the most important books in the field of cardiology, Diseases of the Heart and Circulation. His name has been associated with many groundbreaking papers, including the one on Eisen-Menger syndrome that we very well know of. His book is actually the first one to have a solid chapter on congenital heart disease. The world had come a long way by the time it was 1950s. Now, unfortunately, Dr. Wood died prematurely from a myocardial infarction, but 2 of his students went on to lay the foundation as founders of the field of adult congenital heart disease. One of them, Joseph K. Parloff. After serving 3 years in the Navy in the South Pacific, he went with a scholarship, a Fulbright scholarship, to the Heart Hospital in London and studied with Dr. Wood. He went on to establish the first center and the largest one in North America in 1980 to take care of adults with congenital heart disease. Another student was Dr. Jane Somerville, who studied with Dr. Wood at the Royal Brompton Hospital and then went on to become the European founder for the field of grown-up congenital heart disease. Now we have an international society for adult congenital cardiac disease and continue to make new history. We already heard about the history of echocardiography, and also many of us know Dr. Lee Frazen, who actually designed the first TE probe. We have been riding the wave of new technology over the last 40 to 50 years, and these advancements in pediatric medicine as well as surgery, along with the imaging, have allowed our young children born with heart defects to live into adulthood. However, the indications, frequency, and the type of echocardiogram performed depends upon the patient's condition, the body habitus, and the clinical presentation. I must say, with 3D echo, you can't make pretty pictures for everybody. It's garbage in and garbage out. If you don't have a good transthoracic, you will not get a good 3D, even though you may try. Now, transesophageal has overcome that problem, and the beauty of 3D TE is you can make those beautiful pictures that Dr. Munkut shared with us and others have shared with us today. Now, in the interest of time, I shall just focus on a few defects to show how in our day-to-day practice there's clinical impact with these modalities. We all are familiar with the various types of atrial septal defects. However, the commonest one we see in our practice is the secundum ASD, and the transesophageal echocardiogram over the years has really helped us define the defect, and also with the agitated contrast study shown us the negative contrast with the left to right shunt and the right to left shunt with the positive bubbles. Now, a person who's had atrial septal defect for a long time, like this person who's in her 50s and presented with dyspnea and palpitations, you will see there's marked right heart enlargement due to long-standing left to right shunt. Color Doppler will clearly show that the shunt as well. And then it's important to look at other features as well. Always do a complete study, because if we are planning to do an intracardiac device closure, we will need to advance through the femoral artery into the descending aorta, and this patient, as you can see, has aortic atherosclerosis, which could potentially cause cholesterol emboli. Transesophageal echocardiogram in orthogonal views has also helped us take measurements as a break in a line, as Dr. Pandin has previously described, but then over the years with 3D echo, we've turned that into an actual hole, which I'll show in a minute. But the big dilemma in clinical practice is, should we close or not close this atrial septal defect that we so easily diagnosed with our echocardiography? I'll briefly mention that by the age of 60 years, 90% of patients are very symptomatic with exertional dyspnea. And if uncorrected, until the 5th or 6th decade of life, there's a very high incidence of mortality. Also, the incidence of atrial fibrillation and flutter increases after the 4th decade. And then there are other long-term complications like heart failure, pulmonary hypertension, the risk of thromboembolic complications that are impacted by delaying closure. So the 3D echocardiography has beautifully shown us what the rims are. Are they adequate for inserting a device? Or should this patient be referred for surgery? Also, we see the relationship to surrounding structures, because if the device is too large, it may impinge upon the surrounding structures, especially the aortic valve or the pulmonary veins. We were using intracardiac echocardiography or ICE for a long time, but now with real-time live 3D TEE, we have moved on and away from ICE. We can also assess the adequacy of closure with the TEE, and 3D gives us a better idea about the morphology post-closure. Moving on to bicuspid aortic valve, which is a very common defect, we get a very good idea about the morphology with regular TEE. Like here you can see that the bicuspid aortic valve is formed by fusion of the non-coronary and the right coronary cusp. You can see the raphe here. It's also important to note that in the parasternal long axis view on transthoracic echocardiogram and the TEE long axis view, you can clearly see a domed valve, but do not forget to take measurements along the aorta. The ascending aortic root is often dilated in these patients. The most common presentation in a young person often is endocarditis, which is quite unfortunate in this day and age of a push for good dental hygiene. Here you can see a person who has actually been on 3 weeks of therapy with intravenous antibiotics, but presented with heart failure. He still has his vegetation.